So with these words, I invite Dr. Monica Mahajan to carry the evening forward. Please, madam, welcome her with a round of applause.
Monica, it's a request from our side. Today we are pretty late, so please be precise and short, and we have Dr. Ripen
Good evening everyone, and as has been told to me, I am going to make it very concise and very precise, unlike the traffic on the road. So let me just start by talking about MASLD and why this term has replaced the earlier terms in terms of NAFLD or in terms of the NASH and the MASH that we used to talk of. So everybody is aware of the extent of the global problem, but we have a bigger challenge in India in terms of the percentage of patients with MASLD is much higher compared to worldwide, something to the tune of 38.6%. And alarmingly so, 35% of pediatric age group with MASLD is a very, very big number. So 1/3 of school children in India have MASLD if you start doing the study. And I was talking to Dr. Gopalan just now, and he said that 10 years back they did a study where they found a very high incidence of MASLD in school children. So that is a genuine problem there. So this is the 2023 survey that we have in terms of the extent of the problem as well as in terms of the awareness about the disease as far as the recommendations are concerned. And unfortunately for us, 1/3 of the people or people who were surveyed had not even heard of this term in terms of NAFLD. And in terms of the key requirements in terms of understanding the disease, it is not just the patients but also in terms of at the level of the physicians that they do not know what to do once they see a fatty liver on an ultrasound report. How do they further approach the patient? That is where the challenge lies. So 50% of healthcare providers are not aware in terms of what to do, how to investigate and how to approach a case of MASLD. And that is why this Indian perspective in terms of managing MASLD becomes very, very important. So let's understand why this term has been coined in terms of metabolic dysfunction associated steatotic liver disease. So the term itself is self-explanatory. If you look at the first word, we are talking of metabolic dysfunction, which can be anything in terms of high blood pressure, diabetes, obesity or dyslipidemia. The second part is, it is an association. It is an association between a metabolic disorder and a liver disease. And what kind of liver disease? A steatotic or a fatty liver disease. So that is why the term is self-explanatory in terms of metabolic dysfunction associated with a fatty or a steatotic liver or MASLD in short. And there are defined criteria when you label it as MASLD versus when you label it in terms of an alcoholic liver disease. So you have terms like a MASLD, then you have a MET-ALD where you have an overlap between metabolism and alcoholic liver disease. And then you have something called as alcohol-associated liver disease. So there is a spectrum of diseases which have been identified and have been defined. And the metabolic parameters associated with MASLD would include obesity, diabetes, hypertension and dyslipidemia. So in India, we know that there is a very, very high association with MASLD and in terms of steatosis as well as in terms of liver fibrosis by the time the patient comes to us. And there are a lot of publications which have been done in terms of the extent of liver fibrosis in the Indian patients along with their BMIs and along with the other definitive criteria. So by the time we diagnose MASLD in the Indian population, there is already a significant advancement as far as the damage to the liver is concerned, and the fatty liver already has associated with a significant steatosis as well as in terms of hepatitis. So when I am talking of steatosis, it is just in terms of the deposition of the fat in the liver, but when I am talking of steatohepatitis, that means that along with the fat deposition, the liver function tests have also started to derange, progressing on from a steatosis to a fibrosis to a cirrhosis, and that is how the disease progresses. So this is in terms of the progression of the disease, where you look at in terms of the progression from fatty liver disease to a steatohepatitis going on to cirrhosis. A large percentage of patients ending up with either liver cancers or ending up with liver transplants and a very high associated mortality. And in terms of the pathological associations, we are very well aware that the patients who have MASLD are at a high risk of MI, high risk of strokes as well as chronic kidney disease. So this is the clinical association of MASLD with all of these diseases, right from the MACE to the peripheral arterial disease, CKD, atrial fibrillation as well as in terms of bradyarrhythmias. And in terms of the screening, how do we go about it? So just in terms of, in short, how do you find out whether a patient has MASLD or not? So the number that we look at is in terms of the amount of alcohol in grams per day. If you look at the permissible limits as far as women are concerned, it is 20 grams of alcohol per day, and in men it is 30 grams of alcohol per day. Once it exceeds a 50 gram in women and a 60 gram in men, then you label it as alcohol associated liver disease. Whereas with less than 20 and less than 30, you would label it as MASLD, and anything between 30 and 50 or 30 and 60 would be labeled as a MET ALD, which is meaning that there is an overlap of metabolism and alcohol contributing. So the grams of alcohol, depending on the kind of spirit being consumed, it's MASLD, MET ALD and alcohol associated liver disease. These are the three categories that you're looking at. The simple way to assess is in terms of doing something called as a FIB score, where you need to know the patient's liver enzymes and the platelet values. Feed it into your phone. There is a FIB4 app which is really easily available online. Feed it on the values on the phone. If your FIB4 score is less than 1.3, your patient is still safe and not in the danger zone. Anything which is a FIB4 score of more than 2.67, it is too late. Refer the patient to the hepatologist. And anything between 1.3 and 2.6, feel free to treat yourself, because that patient you can still manage as a physician. So the FIB4 score is the first deciding point. If my patient's FIB4 score is less than 1.3, I do not need to order a fibroscan. Between 1.3 and 2.6 and anything above 2.6, I would definitely order a fibroscan. So you don't have to waste money on a fibroscan in every patient. You do the FIB4 because every patient will have an LFT and a platelet available. Calculate and then decide whom you're ordering a fibroscan and whom you're not ordering a fibroscan. So FIB4 score is practically something that you should do in every obese patient and every diabetic patient as a routine to see what is their liver like. So once I feed in the values in terms of 4 things in the index, the age, the SGOT, SGPT and the platelet count, the app automatically calculates the cutoff values for me and gives me a score. So in terms of this, it gives me a prediction as to whether this patient is going to progress to fibrosis or not. So 1.3 is the number that you need to remember. A FIB4 score less than 1.3, the cumulative chances of liver-related events are low, and along with that, the all-cause mortality and cardiac events are low. Once the FIB4 score is crossing a 2.67, the higher it goes, the more the outcomes are going to be worse as far as the patient is concerned. So once you've seen the FIB4 score, basis that you order the fibroscan or you look at the elastography, and the elastography gives me 2 values. One is in terms of the amount of fat in the liver, which is the CAP values in terms of decibels per meter. And the other value is the stiffness of the liver, because when the waves are crossing into the liver, the amount of resistance to the waves are experiencing in terms of the shear stress of the liver is measured in kilopascals, and that would measure the liver stiffness. So the more stiff the liver, the more the resistance to the waves when they strike the liver and come back. So bigger the kilopascal values, and that means the more stiff the liver is in terms of the extent of fibrosis. So the kilopascal value gives me the fibrosis, and the CAP value gives me the steatosis or the fat content. So together, when I look at the CAP and the KPA values, then I decide what is the level of extent of damage as far as the patient is concerned. So for KPI values or the fibrosis values, you need to remember one number, that is 7. If the KPI values or kilopascal values are less than 7, then the patient has practically no fibrosis. And the other number that you need to remember is 14, because for hepatitis B, C, alcohol, they are different cutoffs, but an approximate number is 14. So if the kilopascals are more than 14, that means the patient has significant amount of fibrosis and is somewhere in terms of the cirrhosis range. So depending on the values, the chart that comes out, the printout that comes to you will state the patient as a F0, F1, F2, F3, and the worst category would be an F4. And then you look at the CAP scores in terms of the extent of fat in the liver. So if the CAP value is less than 237, your patient is absolutely alright. But the moment it is touching near a 300 or a 293, that means the patient has a significant amount of fat in the liver, which is an S3. So an S1 would mean something like a 33% of the liver is replaced by fat, an S2 would mean 66%, and an S3 would mean a 99% of the liver is all replaced by fatty tissues. So basis this, then you decide what is the level of steatosis, what is the level of fibrosis, does the patient fall into an F1, F2, F3 or F4, and does the patient fall into an S1, S2, S3. So along with that, then you have to look at in terms of what strategies in terms of treatment are you going to offer as far as the treatment of this patient is concerned. So MASLD is now part of the non-communicable diseases that has been included in 2021 as part of the NCD program by the Indian government. And what we need to look at is in terms of first part is how are we going to improve the patient's lifestyle. Second part is in terms of looking at the amount of steatosis or the fat content, and third is in terms of the hepatitis part in terms of the inflammation or the ballooning in the liver which is happening. So there were some drugs which were offered to patients before we had any definitive therapy going on, and some drugs which worked and some drugs which did not work. So there are drugs like metformin where trials have been done, sulfonylureas, statins, fenofibrates, high doses of vitamin E, pioglitazone. So some of these drugs were used in large number of patients in the past till we had no definitive treatment for MASLD available. But now we have specific treatments that are available. So I will be talking of saroglitazar, but let me also enumerate the other drugs which have been approved for the treatment of MASLD, out of which the first drug that you may have heard of in conferences is a drug called resmetirom, which is specifically approved for the treatment of MASLD. Now resmetirom works basically at the level of a receptor in the liver, which is called as the thyroid hormone receptor beta. So what it does is resmetirom goes and attaches to this thyroid hormone receptor in the liver cells. So every tissue in the body has receptors for thyroid hormone. So the liver thyroid hormone receptor beta, when the resmetirom attaches to that, it reduces the amount of lipogenesis and the fatty acid metabolism slows down. And as a consequence of that, the amount of fat reduces in the liver, the amount of fibrosis reduces in the liver. So for any drug to be working, what we are looking at is the drug working both at the steatosis and the fibrosis, or is the drug only working at the steatosis and not improving the fibrosis. I need to improve the KPI values and I need to improve the CAP values. So a drug which works on both will be something which will work. So resmetirom got a fast track approval because what we found in resmetirom was that it works both on the steatosis as well as in terms of the fibrosis. But the caveat to that maestro study for resmetirom was that it does not work in the cirrhotic patient. You can only give it in F1, F2 and F3, but the moment the patient has an F4 or a cirrhosis, resmetirom is not approved for that stage of cirrhotic liver. It is only in the early stages of fibrosis that it will work. Now the Indian equivalent to that, which we've been using for a number of years, is lipaglyn or saroglitazar, because we have enough data to say that saroglitazar works both in terms of steatosis as well as in terms of fibrosis. So we are going to talk about specifically saroglitazar. So saro from Gujarati obviously is the good glitazar. And we did have a the earlier drug in terms of a single mechanism of action in terms of the PPAR gamma, but we need a drug which is a dual mechanism of action. So compared to pioglitazone, which was being used for fatty liver in the past, we now had a glitazar which was a dual mechanism of action in terms of PPAR alpha and PPAR gamma. So that is why we found that this is a much more robust, much better drug in terms of fighting MASLD compared to using pioglitazone as the conventional therapy. So when I'm looking at the dual PPAR agonist, what I'm looking at is that it works both at the level of the PPAR alpha, at the level of the liver, kidney and heart and muscles, and at the level of the PPAR gamma in terms of the adipose tissue. So what these PPAR agonists are, these are receptors where the fatty acid metabolism or the lipoprotein metabolism is going to happen. So compared to pioglitazone, which was a single PPAR agonist, when I have a dual PPAR agonist, obviously it is a much more robust drug, and any drug which works on fatty acid metabolism is going to enhance the breakdown of those fats and improve the fatty acid metabolism, or in nutshell, improve the triglyceride metabolism. Because if you look at the twin cycle hypothesis for diabetes, the hypothesis says that the problem is not the sugars. The hypothesis says that diabetes is the common link is the triglycerides and the fats which are driving the liver and the pancreas together as the two wheels of a cycle. So if I am able to improve the fat metabolism or the fatty acid or triglyceride metabolism, then I am achieving two targets. I am not only improving the triglycerides and the lipid profile of the patient, but overall I am driving the positive direction for metabolism, whether it is in terms of the MASLD, whether it is in terms of diabetes, or whether it is in terms of the cardiovascular risk factors. So that is what we are targeting with saroglitazar, is both these receptors to overall improve fatty acid and triglyceride mechanisms. So if you look at the glucose metabolism and insulin sensitivity index, if we are to do the HOMA-IR levels or the insulin clamp studies, we find that saroglitazar improves the glucose metabolism and improves the insulin sensitivity. It reduces the insulin resistance per se in the patient. And in terms of the other drugs that we have used in the past, for example, we are talking of UDCA. UDCA has not been found to be beneficial in any of the trials and is not recommended by any of the agencies for management of fatty liver. If you are looking at obeticholic acid again, study says that do not use in management of MASLD, it is not recommended. In terms of PPAR gamma agonists, in terms of pioglitazone, there is some indication in terms of recommendations, but compared to pioglitazone, saroglitazar has a better evidence. Vitamin E, there is a PAVEN trial which was done at one point of time. So what they did was that in terms of 800 milligrams of vitamin E instead of the conventional 400 milligram. But what was found in the vitamin E trials was that there is a slight increase in the incidence of prostate cancer as well as in terms of bleeding and bleeding related strokes, hemorrhagic strokes. So that is the reason that vitamin E again itself is insufficient evidence as far as management of MASLD is concerned. Metformin is insufficient evidence. So what are we left with in terms of some of the data is the GLP-1 receptor agonists. We have now data with tirzepatide as well as semaglutide in terms of role in management of MASLD. Specifically, there are both the ESSENCE trial which has come out and the other trials which have come out in terms of the management with oral as well as injectable GLP-1 RAs, and the resmetirom and the saroglitazar. So practically speaking, if I am looking at the three drugs which I can offer in today's date and time, guideline directed, there are only three groups in terms of GLP-1 RAs, resmetirom availability and cost being prohibitive, and saroglitazar which is easily available in our country and has sufficient data. So the trials which have been done for saroglitazar is in terms of the evidence phase 4 trials, where they have found that in terms of the study population, when they were given 1, 2 and 4 milligram of saroglitazar versus a placebo for 16 weeks, you find that there is a significant improvement in the fat content compared to the placebo, as well as in terms of improvement in the fibrosis scores as far as the patient is concerned when you do the NAFLD activity scores. So the efficacy of saroglitazar, everybody in this room I'm sure has used in your patients, and from our own experience, from our own real world evidence, we find that it works very well in terms of improving the FibroScan and the FIB-4 scores. And this is one of the study populations published by Dr. Chaudhary et al. In February 2023, where they have demonstrated in 112 patients that not only the improvement in the CAP scores, but also in terms of the fibrosis scores when the FibroScan was done with saroglitazar 4 mg. So these are the results that they've demonstrated. And then again we have a 96-week study with saroglitazar, which is again showing a 42% reduction in the stiffness of the liver and a 26% reduction in the steatosis in the liver. So the net studies, every one of these, whether this is the big study which was published for 114 weeks of saroglitazar. Again, if you look at the scores, from a 22.8 you are coming down to a 10.9, from a 282 you are coming down to a 241, which is a significant improvement. From a F3 the patient is going to an F1, and from an S3 to a steatosis level of S1, which is a remarkable improvement as far as this molecule is concerned. So these are various case studies and case trials which have been done, and there was always a question in terms of, does saroglitazar worsen the lipid profile, does saroglitazar end up in causing high creatinine levels? So this is the data to show that as far as these parameters are concerned, it does not impact the serum creatinine levels and cause it to go up. As far as the HDL and LDL ratios are concerned, there is no significant worsening in the lipid profile as far as saroglitazar use is concerned. So this is in terms of the recommendations, in terms of the drugs which we talked of today. Vitamin E is not approved for NAFLD, pioglitazole not approved, and UDCA again not approved. So saroglitazar has had approvals and in terms of global consensus guidelines. When we are looking at in terms of mention for saroglitazar as far as MASH in India is concerned, so these are the medications which can be used along with the SGLT2 inhibitors, the GLP-1, metformin, sulfonylureas and insulin. And in terms of the NASL guidelines for saroglitazar, it says the minimum duration of treatment should be 1 year with saroglitazar 4 mg. So the placement of saroglitazar, I'm pretty sure you would be convinced that other than the molecules which are prohibitive in their cost or the patient cannot afford, do not have the required data in terms of approvals compared to all the other molecules that we have in hand, saroglitazar is a tick mark in all of these boxes in terms of approval as an insulin sensitizer, in terms of liver fat reduction, in terms of any kind of safety concerns, there aren't any. So the guidelines from India which are mentioning this is in terms of the LAI, RSSTI and in terms of the INASL guidelines. So all of these recommendations for Society for Liver in India and RSSTI, LAI all recommend saroglitazar as the drug of choice in Indian patients. So just to conclude, when we are looking at MASLD, one is in terms of understanding the term MASLD, that it is not standalone fatty liver that you are finding on an ultrasound report. The moment you see fatty liver on an ultrasound report, please start evaluating the patient as to why does he have a fatty liver. Fatty liver has to have a cause. You cannot have a patient having fatty liver on an ultrasound without having a cause to it. Secondly, look at the patient as a whole. Look at what is his lipid profile. Look at what is his BMI. Look at his waist circumference. Look at his hypertension. Look at his pre-diabetes or diabetes, and then associate the patient in terms of looking at the entire metabolic profile of the patient rather than just saying patient has a grade 1 fatty liver. The third thing that you need to do is download the FIB-4 score in your phones. It is very, very easy to use. Please use the FIB-4 app in your phone and you will be easily able to understand where to order a FibroScan and where not to order a FibroScan. Fourthly, the mainstay of MASLD even today remains lifestyle modification. So spend a few minutes talking to your patient about 30 minutes of moderate intensity exercise at least 5 days in a week. talk about weight reduction to the tune of 7 to 10% in terms of a weight reduction target. And then lastly comes the drugs, in terms of drugs like saroglitazar, which are easily available and have a very proven efficacy and a good track record as far as the Indian population is concerned. So thank you so much for your patient hearing.
I think some of us must be wanting some questions to be answered. So I invite Dr. Lucia sir.
लाइट जला
दो भाई, कहाँ लाइट क्यों बंद कर दी?
Just ask few questions. One is whether fibroscan done at a different location, liver as a large pan, will give different results, or if the probe is by carelessness, not absolutely impacted on the abdominal wall, it will oblique, the result vary. Or if the patient is obese, is it the result is valid or not? That is one. Number two, whether saroglitazar has a known side effect of reducing the fasting sugar. There are some patients who feel extremely fatigued after saroglitazar. Do you recommend using it with caution in patient on anti-diabetic drugs?
So part one of the question is in terms of the technique for fibroscan. So when you're doing fibroscan, you're not looking at one value, you're placing the probe at multiple sites and taking the average value. That's the first part, it's not one value. The second part is in terms of the contraindication to a fibroscan. So any patient who has ascites, you do not order a fibroscan because between the liver and the abdominal wall there is water. So the fibroscan becomes meaningless. So the moment your patient has a decompensated liver disease with ascites, you cannot be doing a fibroscan. As far as obese patients are concerned, the machines are sensitive enough because they are meant to be doing fibroscan on obese patients. So morbid obesity, you can still do a fibroscan. It will be actually highly recommended in an obese patient to do a fibroscan because with the ultrasound you may not be able to pick up the extent of the problem as far as this is concerned. So technique is observer dependent but gives you the averages. You have to know where to order the scan and where it is contraindicated. So a lot of times my students will order a fibroscan in a patient in the ward where the patient already has ascites and I go the next day and cancel it because in an ascites patient you cannot do, the values will change with the water in the abdomen. And third is in terms of interpreting those scans, in terms of looking at the averages. If I do a fibroscan today and I do a fibroscan 1 year down the line, it gives me a prognosis in terms of talking to the patient and explaining to him that you've done good or you've done bad as far as disease is concerned, in terms of telling them when you need a liver transplant or you don't need a liver transplant. So those are the kind of prognostic values as far as fibroscan is concerned. Now in terms of the second part, as far as saroglitazar and hypoglycemia is concerned, in any of the phase 1 to phase 3 trials as well as in terms of the real world studies, saroglitazar is not predominantly an anti-diabetic drug. It does not cause hypoglycemia as a side effect. So you can safely give it in patients without having the risk of precipitating the hypoglycemia. It is not directly working on the glucose, it is working on the fat and the triglyceride metabolism. So saroglitazar will not cause hypoglycemia. You can give it in non-diabetic and diabetic patients alike without reducing the doses of OHAs. It will not cause low sugar at all.
Thank you, ma'am.
Thank you. Thank you, ma'am. We will have the question answer session. After we have a talk from Dr. Ripen. Dr. Ripen.
We welcome Dr. Ripen. We are so honored that you have been able to make it in time. Please come on the stage. I will request Dr. P K Gupta to present a bouquet. Dr. Ripen. Let me introduce Dr. Ripen. Dr. Ripen is the Principal Director of Department of Cardiology at Mass Specialty Hospital, Press Enclave. He is also teaching DNP and Master Class in Physiotherapy. He is in charge of the multi-center trials and research. For example, two very famous trials for Freedom and Stitch. So he is in charge of all those, and he is no stranger to us. We have already listened to him. Today he is again going to, yes, Dr. Suli will present.
Sir.
Yes. Cup of joy. Over to you, sir.
Sir, there is a request. Although we have had this session for half an hour, I would like you to keep it very short. Thank you very much.
I'm always very short. Let's start with the presentation. We have the lights with So I'm going to talk about a very common topic, which is atherogenic diabetic dyslipidemia. We all deal with diabetic patients every day, and we know about this entity also. So it is not a new entity, but I'll just give an overview, and we'll have your inputs also. There are few. It is like a debate and discussion, not like a didactic lecture. So. We take a 58 years old lady who is diabetic, hypertensive. She is already on medication, but still her triglycerides are very high, 270. HDL is low, 32. While the HbA1c is not bad, it is 6.9. So it is not an uncontrolled diabetes. Diabetes is controlled. Even then, on statins, on antihypertensives, and on anti-diabetic medications. She continues to have a high triglyceride level, and this is what we usually see in our clinical practice. A lot of our patients will come with this type of pattern. So what should we do? So this is the case, and let's see what are the data which we have. So this is a small study, 120 patient study which was done in India in newly detected diabetic patients. And it was seen that around 1/3 of the patients were having atherogenic diabetic dyslipidemia. So this is a very small study, but it gives a hint that this is a very common problem. And in fact, it was more in patients with HbA1c more than 8. So if the patient was having HbA1c more than 8, majority of the patients were having this atherogenic diabetic dyslipidemia versus patients with HbA1c less than 8. Though younger patients with HbA1c are well controlled, still the patient was having this type of dyslipidemia. And various theories have been proposed for this. One is the YY paradox, which is labeled, or it is also known as triglyceride paradox, and thin fat Indian phenotype. Both are similar things that Indian patients, their BMI is not that high, but they have a lot of abdominal or visceral obesity, which promotes insulin resistance, which leads to all these things. And in fact, insulin resistance is the central mechanism for atherogenic dyslipidemia, because more is the insulin resistance, more is the release of free fatty acids from adipose tissue, plus hepatocytes, they make more triglycerides, and all this leads to an inflammatory scenario and leading to elevated triglyceride levels in the blood, reduced HDL levels, and the LDL particles become small in size. So that is a shift towards the small dense LDL particles. These small dense LDL particles are more atherogenic or cause more cardiovascular disease as compared to the standard LDL particles. And it has been seen that in diabetic patients, if you have a hypertriglyceridemia, there is more risk of having cardiovascular disease. In fact, a diabetic patient with hypertriglyceridemia has 3 times more risk of having cardiovascular disease. So this is very important, and every 50 milligram deciliter increase in triglyceride leads to around 3.3% increase in risk of CV death, myocardial infarction and stroke, and also 5.8% risk in increase in risk in cardiovascular death. This is from the Bali 2D trial, which was a landmark trial done in diabetic patients having stable coronary disease. And then in a predicament study, it was seen that if the triglycerides are high or remnant cholesterol. Now, remnant cholesterol is the cholesterol which is how it is calculated. You take total cholesterol minus HDL minus LDL. So what is left is known as remnant cholesterol, and ideal level should be less than 30. So if it is more than 30, it means more risk for the patient. So remnant cholesterol means the cholesterol is still linked to the triglycerides. So higher is the remnant cholesterol, more is the risk. So clearly, increased triglycerides, increased remnant cholesterol put you at a higher risk of major adverse cardiac events. So this is a question to the audience that do you consider triglyceride as just a CV risk factor or you consider it as a CV risk marker? So both are different things. One is a cardiovascular disease risk factor or just as a marker that is indicates a patient who is going to have coronary disease. Marker. No, I think the answer will be both. Both. So it is both a risk marker and a CVD risk factor also because if the patient is having high triglycerides, so that puts the patient at a higher risk of having coronary disease, so it is a risk factor also. So now there is index. We talk of insulin resistance, but how to calculate insulin resistance in the daily practice? So there is a very simple index which is known as PYG index, where what they do is that we just need a fasting triglyceride level and fasting blood sugar level, and these two are multiplied divided by 2, and inverse of that is taken as a PYG index, which can be easily calculated in various calculators. You just input the two values and you will get this PYG index. And if this index is more than 8 units, it indicates that patient is having insulin resistance, and this patient is more liable to become diabetic in the future, more liable to have cardiovascular disease in the future. So this marker was studied in pure study, where they found that if this index is elevated, there is a more likelihood that patient will develop diabetes in the future, more likelihood that patient will have increased cardiovascular complication in the future. So this is an important index which indirectly tells us about the insulin resistance which is there in a person. And so besides having elevated triglyceride levels, having that for a longer period of time puts you at a higher risk of having cardiovascular disease. This is a slide which tells us that if the number of times the triglyceride high is more is the risk you carry. So clearly triglycerides is elevated triglyceride not a benign phenomena. We should look at it as an independent risk factor because our focus is always on LDL reduction, and we sometimes miss out on the triglyceride. We think, okay, maybe the patient has taken extra sweet in the night and that's why the TGs are high. But we should be careful about this. And this is again a question for the audience that do you use this index? So highly useful, moderately useful, limited utility. So what is the audience response to this? So I think ma'am will be a better judge because she is treating hypertriglyceridemia and diabetic patient daily. I personally am not using it in my clinical practice, but for a study purpose it is a very good index because it can give a lot of prognostic information to us. And if you want more information out of two simple values, triglyceride and a fasting sugar value, this is a good index to be used for us. Now, what are the guidelines telling about rationing triglyceride? What should we do? So if they say that if the patient is at a higher risk and his triglycerides are on the higher level means more than 200, then he should be given a statin therapy. This is a class 1 indication. So clearly, a patient who is increased cardiovascular disease risk and he has elevated triglyceride levels, the statins are the first drug to be given because most of the patients have elevated LDL also. So if the patient still continues to have a high triglyceride levels, then we can think of non-statin therapy in this subgroup of patients. So in a CVD risk patient, either value cutoff is 200. To reduce pancreatic risk, the ideal value is 500. And for primary prevention, the value is 150. So if ideally we should aim for a triglyceride level less than 150, but the medications are only started if the TGs are more than 200, especially if the CVD risk is high. And this is what is told in various other guidelines also. I am not going to the details of it because they are very complicated and everyone will get bored. But what we should remember is that if we are aiming for non-statin therapy, that therapy is beyond statin, then one therapy which is available in India is now icosapent ethyl, which is a purified form of icosapentolic acid. And this has been shown in studies to reduce cardiovascular events, because no other molecule than statin has been shown to reduce CV mortality, but this has been shown to reduce CV mortality. It was studied in a reduced IT study where it was shown that it reduces MACE by 25%, myocardial infarction by 28%. So this is a very good molecule to be given. Fibrates have very little benefit in cardiovascular mortality, but if the levels are very high, like more than 500, then we need to give both of these molecules, and if they don't work, then niacin can be added to this. So this is a general flow for maintaining this hypertriglyceridemia. Similar, all guidelines are same. I will not go into the details of each. So this is just again a question point that if the patient has a TG is more than 150, 200 or more than 500, what is the importance? The answer is given here, but what is the audience thought on this?
Case by case.
Yeah, agreed. Case by case, sir.
Optimum target level should be less than 150.
Yeah, optimal should be 150.
And if it's more than 500, the risk of pancreatitis is exponentially increasing.
So that is also no debate. And between I think 150 to 500, it all depends on the risk of the patient. So that is a very good suggestion from doctor, that case to case in between levels, but ideally more than 500, it is a very high risk for the patient. So I think cerebral has been discussed by ma'am in detail. I will not touch too much on this, but it is a dual PPAR and agonist, and it has an action on both insulin sensitivity and glucose metabolism. So it lowers the triglyceride levels by 45 to 62%, non-HDL cholesterol by 21 to 36%, LDL also reduction is there, but modest. HbA1c 0.7 to 1.6%, depending upon the baseline HbA1c of the patient. If the HbA1c is high, the benefit is more. HbA1c is low, benefit is less. Also, there is a positive effect on the liver enzymes. So that's why it works in MSLD patients. Efficacy is maintained over 1 year period. The side effects profile is not bad. Main side effect is muscle pain, little bit of muscle pain, GI side effects, and hypoglycemia if given along with other anti-hypoglycemic agents. And if we give it add-on to rosuvastatin, it has a beneficial impact in reducing the triglyceride levels. So I think this is the same, our case. What should we be doing in this patient? Should we increase the dose of anti-diabetic medicines in this patient, or we should give more aggressive lifestyle modification to this patient? Should we add a triglyceride lowering drug like celecoxib or fenofibrate to this patient, or add a non-statin lipid lowering agent like SGMI? Now this patient already has a HbA1c of 6.9. LDL is well controlled, so I think very clear that A and D is not the answer. So I think it's a combination of B and C, more aggressive lifestyle modification. So all patients who have a high triglyceride, we should tell them to reduce, stop alcohol, reduce the fat intake, reduce the sugar intake, increase activity, exercise activity. Along with that, we can add a molecule like celecoxib or fenofibrate to this to bring the levels down. And this is again a survey done in around 553 patients. It was seen that celecoxib in Indian patients reduces the similar things that triglyceride, LDL, and liver enzymes, and also HbA1c level depending on the baseline HbA1c. With no impact on renal function, and we all know that fenofibrate can sometimes impact the renal function a little bit. but cerebrosidol does not have impact on the EGFR or the serum creatinine levels. And this is a study from Mexico which shows that both are given to a patient like one cerebrosidol fenofibrate, the triglyceride reduction is slightly better with cerebrosidol, 55% versus fenofibrate 41%. So this is a very effective molecule, especially in diabetic subgroup. And this is a comparison of the two molecules that fenofibrate only reduces the triglycerides, which has no effect on insulin resistance. Also, it can increase the risk of gallbladder stones. So, if we compare the two, the data is more in favor of cerebrosidol as compared to fenofibrate, especially in diabetic subgroup. And this debate also indicates the same thing, that it is an insulin sensitizer, better TG reduction, less side effect of myalgia, and a neutral impact on serum creatinine and EGFR, irrespective of the CKD stage. So clearly, this is a better tolerated molecule out of the two. And this is my last slide, that due to the South Asian phenotype, the most common form of dyslipidemia in India is high triglycerides followed by low LDL cholesterol. We all see in our clinical practice, patient comes in mild and fraction, the LDL is 110, 120, not never, rarely will be 180 or 160. And in these subgroup of patients, we see that triglycerides are high, HDL is low. So this is a typical phenotype. And insulin resistance is a common soil, I think, for diabetes, high triglycerides, MSLD. And we should do clinical intervention when the triglyceride levels are more than 200, and we can use various agents, out of which cerebrosidol is one of the agents which has multiple beneficial effects. Thank you. I think, sir, I was short and brief as requested by you. Dr. P K, I was short and brief.
Yes, sir. Very good. I have to congratulate Dr. Ripen and Dr. Mahajan for giving such good lecture and very precise. There are a lot of questions in the mind of the audience who are here, because this subject is unique in its own way, especially when Dr. Ripen has said triglycerides, whether they should be reduced or not. Man has given a lot of importance to the fibrosis of the liver, cirrhosis, everything. So I would like to invite all the questions from our audience, but there has to be very short and it should take not more than 5 to 10 minutes. Thank you very much, sir.
Thank you, Dr. Ripen और Dr. Monica both can answer. एक उधर बुला लीजिए ना। Dr. P K मैं इधर हूँ। आगे आओ ना।
Ajo, please. You have to
Let both the speakers sit there. इधर आ।
माइक हो जाएगा सर।
माइक दे दो।
ये वाला भी अच्छा वो वाला दे दो। ये ले लो।
So any ये तो फाइनल है ना। अरे दो आ गया ना। Sir, this is a very good molecule, like both of you wrote the benefits. So why it is not so popular? Because it is an Indian molecule and not accepted by.
So, in India we are using it very frequently, and but in I think it's not USFDA approved. Reason is that for USFDA approval you need very big trials and lot of money power. Indian companies still don't have that.
Money तो आजकल इंडिया में company है.
Yes, sir, for trials it need a lot of this thing. So sometimes US.
But you are convinced that this is a very good molecule. One Indian doctors.
Indian scenario is very good. Whatever data we have is positive.
Is there anybody in the room who is not written a Lipaglyn prescription? Please raise your hand. Anybody who's never used Lipaglyn?
But anyway.
It's a popular molecule.
Yes. No, so you in your slide, I think you didn't show that it increases HDL. In your slide, it was you know, it lowered LDL, it lowered triglyceride, but it didn't show that it increases anything.
Main action is to lower triglycerides. HDL improvement or HDL you see there were a lot of trials that 20 years back where HDL was improved by 100%, 35 or 70, but no reduction in events was seen. So I think HDL is the overall right now. That's my concept.
So focus should be on LDL lowering.
LDL and triglycerides.
So from my side it's over.
So you use the new term, remnant cholesterol.
Yes, sir.
The non-HDL is total minus HDL.
Yes, sir.
This you said is total minus HDL minus LDL.
Yes, sir.
So this is equal to VLDL.
Yeah, definitely, sir.
So why a new term when it is only VLDL?
So that's why remnant cholesterol means that how to calculate the remnant cholesterol. So remnant cholesterol indicates the cholesterol bound to triglycerides. So that is if it is high, it is risk for the
So let me begin by saying those were two wonderful, excellent talks to Dr. Monica. Lancet Hepatology, lot of excitement on lipoprotein circulatory lipoprotein with transaminitis may present novel biomarker to predict progression to fibrosis. How important is the circulating lipoprotein LDL may be normal. Is this a marker for progression to fibrosis, ma'am? This is what the Lancet Hepatology said, not mine.
So there's enough data on lipoprotein A, but if you look at in terms of the practical situation, do you have any treatment to offer to a patient with high lipoprotein A?
We have.
Okay, so we are looking at drugs which are in hand, whether we are looking at in terms of your PCSK9 or whether you're looking at in terms of the small RNA molecules, in terms of the glycerides or in terms of your bempedoic acids. As of date, in the clinical setting, you're still looking at the lipid profile or the extended lipid profile, and in the Indian setting, you're looking at in terms of the non-HDL. So there is lots and lots of study, not just in the Lancet, but in every cardiology journal on lipoprotein A. But for practical purposes, if I'm looking at the non-HDL in my patient, that's good enough for me to treat that. And the definition of MASLD only includes triglycerides and LDL. It is not even looking at lipoprotein A. As far as all the Gastroenterology Society guidelines are concerned, they don't talk of lipoprotein A. For definition of MASLD, hypertension, pre-diabetes or diabetes, and in terms of the LDL and the triglycerides, these are good enough to label a patient as MASLD. I don't need any more information that is needed for my patient.
So ma'am, would you say what is the correct definition? Is it the MASLD or the method? Because
that debate has already been finished.
this was changed in 2023.
Yeah, so we are in 2025.
What do you think is the correct definition?
I've just shown you that slide, sir, with the explanation as to what is the metabolism, what is the association, and what is the liver disease. So that debate is already over in the last 2 years. It is MASLD everywhere now. For uniformity of doing all the trials, for doing all the drug trials.
You said MASLD. Or is it MASLD?
MASLD, sir. MASLD.
MASLD.
Absolutely.
Okay. So, there have been some serious concerns regarding this definition. Lack of specificity and poor diagnosis, lower preference, lower performance in detecting hepatic and extrahepatic outcomes as compared to the method. So, I don't know which is the correct terminology, MASLD or method. Like to say something about that, Dr. Ripen?
I think what ma'am said was that right now it is MSLD only. Right? Maybe later on it will change something.
It will change, surely. Okay, let me proceed further, ma'am. Regarding the most recent AACD guidelines, we talked about the importance of lifestyle modifications. The evidence of low glycemic Mediterranean diet is very strong. So, which reduces NAFLD score within 6 months.
See, the NAFLD score reduced within 6 months if you follow a low glycemic vegetarian diet. Your impressions on that?
Most of the topmost athletes in the world, most of the topmost swimmers, most of the topmost wrestlers are all vegan. They are not even vegetarian, they are vegan. So I'm totally agreeing with what you're saying. There is nothing extra that you get in a non-vegetarian diet that you can't get in terms of the content of the food in a vegetarian diet. And vegan is even better than vegetarian. So a Mediterranean diet is the best form of diet as far as MASLD is concerned.
My last question to you will be regarding the Triumph 3 trial.
What specifically do you want on that?
So I want to know whether the retatrutide, the triple agonist, reduces this hepatic steatosis to a large extent. They said it reduces complete resolution of hepatic steatosis in 90% of the patients within 48 weeks. So this was what the Triumph 3 trial said. Your impressions on that?
So if you look at the journey of the GLP-1 RAs, the difference between semaglutide and tirzepatide is that semaglutide is a GLP-1 RA, whereas if you look at tirzepatide, it is GLP-1 and a GLP-1, and then when you look at retatrutide, it is a triple agonist. So the more number of target that you have, the better it is going to be as far as MASLD is concerned, and that is what the data shows, that tirzepatide is better than semaglutide and retatrutide is better than tirzepatide. So I think in the next 3 years there are at least 3 different GLP-1 RAs which are almost on the verge of getting an approval. If you look at the NEJM this month, there is a new molecule which is an oral GLP-1 RA which is called as orforglipron, which has been already approved, which is a next generation oral GLP-1 RA. So next year you will not have only semaglutide as oral, you will also have orforglipron as the second oral GLP-1 RA. So next 5 years the market is going to be flooded with any number of GLP-1 RAs, whether it is in terms of single, dual or triple. You have already one molecule in China which is again a triple, which has already been used in trials. So next few years you will get enough molecules of this class to be working on as far as MASLD is concerned.
Dr. Ripen, to you. So Jack.
Thank you so much, sir. There are other people as well who would like to ask any questions.
Let me complete. So Dr. Ripen, 2nd June 2025, ACCHA guidelines recommended that regarding the LDL goals, they said individualized LDL goals. If you have a very high risk, probably your LDL level should be less than 40. If you have high risk, 55. If you have moderate risk, about 70. And if you have low risk, less than 100. So your impressions about the LDL goals individualized according to the patient's profile.
So I totally agree. LDL number is a moving number. So when I started my clinical practice 30 years back, 130 was considered very good. So we are going down. Now they consider 30 is good. So
Lower the better.
Lower the better, because there is a linear relation between as the LDL goes low, events become low. And now they say that even 2025 is good enough for survival.
What about single digits?
Yeah, maybe, sir, we don't know the answer, but it is going down.
Absolutely. So correctly said. Talk us about the FOC3 inhibitor. I'm referring to the Elizarsen, which is highly recommended in patients who have very high triglycerides to prevent pancreatitis. Triglycerides level more than 500. The H3 receptor.
Right now, I have not used it, so I don't have a clinical experience. But the recommendation is that first we should try the other modalities. There is a lifestyle modification, niacin, giving omega-3 fatty acids, and phenolphthalein.
My last question would be regarding the recent again guidelines.
I would request you to refrain
Which
it.
suggests
We have other delegates as well.
that you do not de-escalate statin therapy post ACS.
Yeah, it should never be de-escalated.
Never be de-escalated because it would increase seriousness. Thank you, sir.
Thank you so much, sir.
Dr. Tulsi, wonderful questions you asked. And really, it's a very pertinent question. I'd just like to respond to your first question, MASLD and NAFLD. Absolutely no controversy. Dr. Monica will also second me on this. Adult or pediatrics. NAFLD term has been replaced by MASLD. Absolutely. So it's because the term non-alcoholic fatty liver disease is now no longer.
We have had a very long discussion. I have one or two questions more, and after that, no questions. If anybody wants to ask, please ask.
The second question is, Dr. Monica, first, wonderful presentation by both of you. When it comes to pediatrics, it's either diet or physical activity or a combination of both. Drugs don't work in fatty liver disease in children. That's the convention. But of late, there's a lot of new information coming in. India, unfortunately, from the legal perspective, drugs are not licensed for use for NAFLD or NASLD in children. My colleague, Pankaj Bova, whom you know quite well, he in the US is using semaglutide, left, right and center in anybody more than 7 years of age in children and with wonderful results. Dr. Amnish Mittal was here 2 weeks ago for another presentation and I shared data with him and he said liraglutide, we've had excellent results in non-alcoholic fatty liver disease in children.
Short.
No, the question is, when it comes to drugs in pediatrics, is there a role in NAFLD or MASLD? I'm just giving you data which people have said. Is there any role?
So both semaglutide in terms of use of Wegovy for obese pediatric children, as well as in terms of liraglutide in terms of obese adolescents, there are data and there are both trials and studies for both these molecules in adolescent obese patients. We will have to use it off-label because as of now DCGI has not given an approval, but on a case-to-case basis off-label you can. In US, I do have children who are on both Wegovy as well as in terms of Mounjaro on a case-to-case basis, including some of the patients who I personally know who have been prescribed by their pediatrician. So in US, both Wegovy as well as Mounjaro are approved in people less than 18 years of age with morbid obesity. In India, we will have to still wait for that approval because for any DCGI approval, you have to have Indian studies and Indian data. And that is the reason that both these companies have not been able to get that approval because we lack Indian data. That is the only reason. So otherwise, they can be used.
This is exactly what I want all of you to push.
My question is that now we are focusing a lot on ApoE delay or LP disease, and since this is a marker of Dr. Ripen Gupta particularly. So, would you, as of now, as far as I know, there is nothing which has come out in the market in the pharma which can reduce LP delay or PCSK9. PCSK9. Inclisiran as well. Inclisiran, yes, inclisiran maybe. But we are not using inclisiran that often. PCSK9. PCSK9. Okay, sir, but I would like to.
We have in the last 1 year used in selective high-risk patients inclisiran with very good responses in their entire lipid profile and their LPA value. So at least I have myself used in 4 patients inclisiran, 2 injections each. 1 patient 3 injections because very high risk ASCVD and very remarkable results. But whether that will, in terms of justify, will it increase their number of years of life or is it only going to show on the lab reports and an improvement? I still don't know. It's an expensive molecule. The company has 1 injection.
Anything less than inclisiran, anything less than that.
Nothing less than inclisiran works on the LPA.
Little protein A. Very much Dr. Monica Mahajan and Dr. Ripen Gupta to come here and to address us in a very sort of orderly way and very nice. I am thankful to you we would like to ask more questions from you, sir. And, but you will have to give us one more CLA.
Sir, only one more. Only one more.
We are not planning it in Durga Puja days. Next time I'm not coming.
Diwali days.
Sorry, not Diwali, not Durga Puja.
New Year.
Sorry, you guys are not